Hey everyone, and welcome to the Deep Dive. Today, we're tackling something that, well, it touches so many lives, but often gets lost in medical terms. Chronic stable angina pectoris.
That's right.
We've pulled together insights from this PPPB5 angina pectoris.pdf
hmm
to really get to the heart of what's going on.
hmm
Our mission is to move beyond just the name and truly understand the intricacies of this common heart condition. And trust me, there are some surprising things we'll uncover, some crucial distinctions.
And that's exactly why this is so valuable, I think. Understanding the underlying mechanisms of conditions like angina and how different factors and treatments connect. It really empowers you with knowledge about your own cardiovascular health or, someone you care about
Definitely. It's about building a clearer picture.
from the ground up. Yeah.
Okay, let's unpack this then. What exactly is chronic stable angina pectoris?
hmm
At its core, it's chest discomfort. It arises from what doctors call myocardial ischemia.
Right.
Now, myocardial ischemia,
Hmm.
that's a bit of a mouthful, isn't it?
It is.
But think of it like your heart muscle literally being starved for oxygen, kind of like a runner's leg muscles cramping up when they're not getting enough blood.
Good analogy.
And this happens specifically because of a fixed obstruction in the epicardial coronary arteries, so the main blood vessels on the surface of the heart.
Exactly. And fixed is the key word there. It's not a temporary spasm, it's a constant blockage, like a permanently clogged pipe.
Right, a supply and demand problem for your heart.
Precisely. And this discomfort, it's typically a complication of coronary artery disease, CAD, usually caused by atherosclerosis, the hardening and narrowing of those coronary arteries.
Okay.
The fundamental imbalance in myocardial ischemia is really a mismatch. Your heart's oxygen demand goes up.
Mhm.
Maybe you're exercising, maybe stressed.
Right.
But the blood supply through those narrowed arteries just can't keep up.
And what increases that demand?
Things like an increased heart rate, higher blood pressure, increased contractility, how hard the heart muscle squeezes, and greater wall tension. Basically, anything that makes the heart work harder.
Okay, so we've got a picture of what angina is. Now let's talk about who. Who often finds themselves grappling with this? Because it's not always who you might expect, is it?
No, not always. And understanding the risks is, well, it's crucial.
Let's talk about the major players then. For chronic stable angina pectoris, diabetes mellitus. That's a huge one. And here's something that really struck me. It's considered the worst risk factor, and even a CAD equivalent.
It is. And what's really surprising or maybe alarming about diabetes is how it can sometimes mute the classic angina pain.
Mute it. How?
It can lead to what we call silent ischemia. The heart muscle is being starved of oxygen, but the patient doesn't feel that typical chest discomfort because nerve damage from the diabetes can affect pain perception.
Wow. So someone could be having a serious issue and not even realize it in the classic way.
Exactly. It makes diagnosis incredibly tricky sometimes. It's a prime example of why classic symptoms aren't the whole story.
That's really important to know. What else?
Well, beyond diabetes, smoking is highlighted as the most important modifiable risk factor.
Modifiable.
Yeah.
Meaning you can do something about it.
Precisely. That's where you have agency, which is powerful. Then you have hyperlipidemia, high cholesterol hypertension, being male, age, typically over 45 for men, over 55 for women, and of course, family history of coronary artery disease.
So those are the big ones. Are there others, maybe less common ones?
Yes, there are minor risk factors too. Things like obesity, elevated homocysteine levels, increased C-reactive protein, which is a marker of inflammation, and lack of estrogen.
Okay.
And what's also fascinating is how other seemingly separate conditions are considered CAD equivalents. They put you in the same high-risk category.
Like what?
Things like carotid artery disease narrowing in the neck arteries, an abdominal aortic aneurysm, peripheral arterial disease, poor circulation in the legs, or even just having a calculated 10-year risk of a heart attack that's 20% or higher.
So it really shows how interconnected the whole vascular system is, doesn't it? And trouble in one area often signals trouble elsewhere.
Absolutely, it's all linked.
So, okay, we understand the mechanics, the risks, but what's it actually like to live with angina? Let's peel back the layers on the symptoms. What does this chest discomfort really feel like? And maybe some ways it doesn't feel like you'd imagine.
Right, the classic presentation, the one you read about, is chest pain or discomfort that's substernal right behind the breastbone.
Okay.
It's often poorly localized, meaning it's hard to point to one specific spot. It's exertional, brought on by activity or stress. And it's short in duration, usually less than 30 minutes, often resolving within just, say, 5 minutes of stopping the activity.
And relieved by rest.
Right.
Or medication.
Exactly. Relieved by rest or nitroglycerin. And it can radiate, travel to other areas.
Where might it radiate?
Common spots include the arm, often the left, but not always the teeth, the lower jaw, the back, the epigastrium, which is the upper abdomen, or the shoulders.
Okay, that's the classic picture. But you hinted it's not always like that.
And here's where it gets really interesting, because not everyone feels that classic chest pain. We have something called anginal equivalence.
Equivalence, meaning other symptoms that signal the same underlying problem.
Precisely. Patients might experience shortness of breath or dyspnea, or they might feel pain just in the epigastric region, upper belly pain, easily mistaken for indigestion, or even just shoulder pain instead of chest discomfort.
Wow. And who tends to get these equivalent symptoms more often?
This variability, it's especially seen in women, the elderly, diabetics, tying back to that potential nerve issue, and obese patients.
So that really complicates things, doesn't it? You hear hoofbeats, think horses, not zebras. But sometimes, with angina, you do need to think about those zebras, especially in these groups.
You absolutely do. It must make diagnosis incredibly challenging sometimes.
That's truly fascinating. Does that mean a lot of people might just dismiss these symptoms, think it's indigestion or a pulled muscle, maybe delay getting help?
Absolutely. It's a significant challenge. That's why awareness of these anginal equivalents is so vital, both for patients and clinicians.
And what about a physical exam? If someone goes to the doctor, what might they find?
Well, another important point is that often the physical examination during these episodes, or even between them, is usually completely normal.
Really? Normal?
Yeah, a doctor might listen to your heart, check your blood pressure when you're feeling fine, and not find anything obviously wrong.
So how do doctors figure it out then? If symptoms vary, the exam might be normal. How do you pin it down?
Well, stable angina is usually a clinical diagnosis. That means it's based heavily on the patient's story, those symptoms we discussed, combined with specific testing.
Okay, what kind of tests?
The initial test of choice is usually the electrocardiogram, the ECG.
Right, the one with the sticky pads.
That's the one. Classic findings on an ECG can include things like ST depression, that's a specific dip in the electrical waveform, either horizontal or downsloping, or T-wave inversion, poor R-wave progression, T-wave pseudonormalization, specific electrical patterns.
But you said can't include.
Right. And here's a crucial distinction, maybe a surprising fact. The resting ECG can actually be normal in 50% of cases.
50%,
Yeah.
half the time.
Half the time. So you can't just get a quick ECI check and assume everything's okay if it's normal. It really underscores why doctors often need to, dig deeper.
Okay, so if the resting ECG can be normal, what's next?
That's where stress testing comes in. It's really the most important non-invasive testing strategy.
Making the heart work harder to see what happens.
Exactly. There are a few key options. The stress ECG is the most common. You walk on a treadmill or use a bike while hooked up to the ECG.
But you said the resting ECG might be normal.
Right. So the stress ECG is generally most useful if the baseline resting ECG is normal. Positive findings would be seeing those ECG changes appear during stress, or if the patient's typical symptoms are reproduced.
Makes sense. Any limitations?
The main limitation is that it doesn't pinpoint where the ischemia, the lack of blood flow, is happening in the heart.
Okay, so what tests can show the location?
For that, we move to imaging tests. One is myocardial perfusion imaging, or MPI.
How does that work?
It uses small amounts of radioactive tracers, like thallium or technetium. These tracers are taken up by the heart muscle according to blood flow. So areas with poor flow show up differently on the scan.
Ah, okay. And this works even if the baseline ECG is abnormal.
Yes, and it's excellent because it gives information on both the location and the extent how much heart muscle is affected by the ischemia.
Can everyone do the exercise part?
No, and that's important. MPI can be done with exercise, but if someone can't exercise adequately, we can use pharmacologic agents, medicines that mimic the effects of exercise on the heart's blood flow. These are usually vasodilators like adenosine or dipyridamole.
Are there special preparations for that?
Yes. If you're having a pharmacologic stress test with these agents, you typically need to stop theophylline, that's an asthma medication, 48 hours before, and caffeine 12 hours before.
Good to know. And are there people who can't have those vasodilator drugs?
Yes, there are contraindications. For instance, people with severe bronchospastic disease like bad asthma or COPD shouldn't get them because they can worsen breathing problems. Also, very low blood pressure or certain heart rhythm problems like high-degree AV blocks are contraindications.
Okay, what's another imaging option?
Another good one is stress echocardiography.
That's ultrasound of the heart.
Well, exactly. An echo uses sound waves to create pictures of the heart beating. During a stress echo, we compare images taken at rest with images taken during peak stress, either exercise or medication.
And what are you looking for?
We look for changes in how parts of the heart wall are moving. Areas that aren't getting enough blood flow won't contract normally under stress. Like MPI, it's useful if the baseline ECG is abnormal, and it also gives information on location and extent of ischemia.
Can this also be done with medication instead of exercise?
Yes. For stress echo, the medications used are usually positive inotropes like dopamine or dobutamine. These make the heart beat faster and harder, simulating exercise.
Any contraindications for those?
Yes, things like severe aortic stenosis, which is a narrowing of the main heart valve leaving the left ventricle, certain ventricular arrhythmias, a very recent heart attack within 1 to 3 days, or severe, uncontrolled high blood pressure.
Okay, now you mentioned anti-anginal medications earlier. What about taking those before a stress test? Should people stop them?
That's a very important point, and it depends. If you don't have a known history of coronary artery disease, then yes, antianginal meds like nitrates, beta blockers, calcium channel blockers should typically be withheld for 48 hours before the test. We want to see the heart's underlying response.
But what if someone already knows they have CAD?
Then, generally, they should continue their antianginal medications. The purpose of the test in that case is different. It's to evaluate how well the current treatment is working and to help determine a safe level of exercise for them. We're testing the treated heart, you see.
That makes sense. Testing the effectiveness of the therapy itself. Okay, so we've covered non-invasive tests. What if those aren't clear, or if the doctor suspects something more serious?
Right. If we need the absolute clearest picture, or if we're strongly considering procedures like stenting or bypass surgery, then we move to the gold standard test.
And that is,
Coronary angiography, sometimes called cardiac catheterization.
how does that work?
It's an invasive procedure where a thin tube, a catheter, is guided through blood vessels, usually from the wrist or groin up to the heart. A special dye is injected directly into the coronary arteries, and X-ray videos are taken.
And that shows blockages.
Exactly. It literally outlines a coronary artery anatomy. It defines the exact location and the severity, the extent of any coronary artery disease.
When's this usually done?
It's indicated to confirm or rule out CAD in patients with symptoms, especially if non-invasive tests were unclear or conflicting. Or, crucially, for patients who might need revascularization, that means procedures to restore blood flow, like angioplasty, PTCA, or bypass surgery, CABG.
Okay, so once angina is diagnosed, let's talk management. You mentioned a typical outpatient regimen, often involving 4 key drugs. What are they, and why these 4 specifically?
Yes, these 4 often form the cornerstone of medical management for stable angina. First, and arguably most importantly for long-term outcomes, are beta blockers.
Why are they so important?
They are considered the most important drug class to decrease mortality in patients with CAD, especially after a heart attack, and they are typically first line for long-term angina therapy.
How do they help with angina itself?
They work by decreasing the heart rate and the force of the heart's contraction, or myocardial contractility. They also lower blood pressure. All of this reduces the heart's oxygen demand. Plus, by slowing the heart rate, they actually increase the time the heart spends in diastole, which is when the coronary arteries fill with blood, improving supply. They help delay angina onset during exercise.
Are there times you wouldn't use a beta blocker?
Yes, a critical contraindication is in vasospastic angina, also called Prinzmetal angina.
Why is that?
Prinzmetal angina isn't caused by fixed blockages, but by sudden spasms in the coronary arteries. Beta blockers can sometimes leave the effects of adrenaline on certain receptors unopposed, potentially making those spasms worse. So, different mechanism, different treatment approach.
Got it. Okay, drug number 2.
Second is short-acting nitroglycerin, usually a small tablet or spray under the tongue.
What's its role?
This is your first-line therapy for immediate relief of acute anginal symptoms. It acts very quickly, usually within 1 to 2 minutes.
Does it also improve long-term survival like beta blockers?
No. And this is vital to remember. Nitroglycerin has no mortality benefit. It's purely for symptom relief.
How does it work so fast?
It works mainly by relaxing blood vessels. It causes venodilation, meaning it relaxes the veins, so less blood returns to the heart, reducing its workload. It also causes some arterial vasodilation, further reducing the pressure the heart pumps against. This decreases the heart's oxygen demand and can also slightly increase supply by dilating coronary arteries.
How is it typically used?
It's taken sublingually under the tongue as needed for chest pain, usually up to 3 doses 5 minutes apart. If the pain isn't relieved after 3 doses, that's a medical emergency, could be a heart attack. It can also be used prophylactically, meaning taken before an activity known to cause angina.
Any side effects?
Yes, mostly related to the vasodilation. Headache is very common, flushing, low blood pressure, hypotension, and sometimes peripheral edema or swelling.
What about tolerance? Can the body get used to it?
Yes, tolerance or tachyphylaxis can develop with continuous use. That's why for long-acting forms, we need a nitrate-free period each day. For the short-acting form, it's less of an issue with as-needed use, but important to know. Also, the pills are sensitive. They deteriorate with light, moisture, and air, so they need proper storage.
And any critical interactions?
Absolutely critical.
Uh,
Nitroglycerin should never be used with phosphodiesterase 5 inhibitors drugs like sildenafil, Viagra, tadalafil, Cialis. The combination can cause a severe, potentially life-threatening drop in blood pressure.
okay, that's a huge warning. Drug number 3.
Third is aspirin.
Good old aspirin. Why is it included?
Daily aspirin, usually a low dose like 81 milligrams, sometimes up to 325 milligrams, is recommended for basically all patients with established cardiovascular disease, unless they have a specific contraindication.
Why? Does it help with symptoms?
Not directly with angina symptoms, but it provides a significant mortality benefit. It works by preventing platelets from clumping together, reducing the risk of forming blood clots that can cause heart attacks or strokes. It reduces the risk of subsequent MI, stroke, and vascular death.
That's a powerful benefit. But aspirin has risks too, right? Especially bleeding.
Absolutely. The most important risk is major bleeding, particularly gastrointestinal bleeding, like stomach ulcers or bleeding, and also intracranial hemorrhage, bleeding in the brain.
That sounds significant. How do doctors balance that risk versus the benefit?
That's an excellent question, and it's a constant calculation. It's where personalized medicine really comes in. For most people with established CAD, the benefit of aspirin in preventing clots outweighs the bleeding risk. But the doctor has to weigh individual factors: age, history of ulcers or bleeding, other medications.
What if someone can't take aspirin? Maybe they're allergic or have had serious bleeding.
For those patients, an alternative antiplatelet drug like clopidogrel Plavix is a reasonable alternative.
Any other aspirin side effects besides bleeding?
Yes, gastric upset or ulceration, even without major bleeding. It can sometimes cause renal injury. And hypersensitivity reactions can occur, especially in people with nasal polyps. It can trigger asthma attacks and what's called aspirin-exacerbated respiratory disease. Higher doses can cause tinnitus, ringing in the ears, vertigo, and changes in acid-base balance.
And there's a warning about kids, right?
Yes, a critical warning. Aspirin should generally be avoided in children and teenagers with viral infections because of the increased risk of Reye syndrome, a rare but serious condition affecting the liver and brain.
Okay. And the 4th drug in the typical regimen?
And finally, number 4 is a statin. Drugs like atorvastatin, simvastatin.
Or cholesterol?
Exactly. Essential for managing hyperlipidemia, lowering LDL or bad cholesterol, which is a major driver of atherosclerosis, the underlying cause of the angina. Statins also have plaque stabilizing and anti-inflammatory effects beyond just lowering cholesterol.
So those are the core 4. Beta blocker, nitroglycerin, PRN, aspirin, statin. What if that's not enough? Or if someone can't take, say, a beta blocker? Are there alternatives or add-ons?
Absolutely. If beta blockers are contraindicated, maybe due to severe asthma or side effects, or if angina persists despite the beta blocker, then calcium channel blockers or CCBs are often the next step. Long-acting nitrates can also be used.
Which calcium channel blockers are preferred?
Generally, the preferred types are either the long-acting non-dihydropyridines, like diltiazem or verapamil, or the second-generation dihydropyridines, like amlodipine or felodipine.
Why those specific ones?
It's crucial to avoid short-acting dihydropyridines, especially nifedipine, unless the patient is also on a beta blocker. There's evidence that using short-acting nifedipine alone might actually increase mortality or heart attack risk, possibly due to rapid drops in blood pressure triggering reflex tachycardia.
That's important. Do CCBs offer the same survival benefit as beta blockers?
No, and this is another vital distinction. Unlike beta blockers, calcium channel blockers have generally not been shown to reduce mortality after a heart attack. In fact, some studies suggested certain ones could even increase ischemia or mortality in that setting. So they're mainly for symptom control or used when beta blockers aren't an option or aren't enough.
Okay. And you mentioned long-acting nitrates as well.
Yes, these come in forms like oral pills, ointments, or skin patches. They provide longer-lasting vasodilation than the short-acting spray or tablets.
Do they have the same tolerance issue?
Right. Yes, tachyphylaxis is a major issue with continuous use. To prevent tolerance, patients using patches need to have a patch-free interval each day, typically 10-12 hours, usually overnight. A minimum of 8-10 hours nitrate-free is needed.
What are their side effects?
Similar to short-acting nitro, tolerance is the main limitation. Also, headache, flushing, low blood pressure, lightheadedness, and sometimes peripheral edema. And the same critical contraindication applies. Do not use with phosphodiesterase inhibitors within 24 hours.
Okay. Is there anything else in the medication toolbox for angina?
There is one more notable drug, ranolazine. It's kind of unique.
How does it work?
It works differently from the others. It's a late sodium channel blocker. By affecting sodium entry into heart cells during the later phase of the heartbeat, it indirectly reduces calcium overload, which helps the heart muscle relax better and reduces its oxygen requirements. Importantly, it does this without significantly affecting normal heart muscle function.
What's the benefit of that?
It's effective in reducing anginal symptoms and improving exercise capacity, especially for patients whose angina isn't well controlled by the other therapies, sort of refractory angina.
Any advantages over other meds?
Yes, some nice features. It generally has no significant effect on heart rate or blood pressure, which is helpful. It's considered safe to use with erectile dysfunction medications. Some studies suggest it might decrease the occurrence of atrial fibrillation and cause a small decrease in HbA1c in diabetics. And interestingly, even though it can prolong the QT interval on the ECG, it seems to be associated with a lower rate of serious ventricular arrhythmias compared to other QT prolonging drugs.
Is it for acute attacks?
No, absolutely not. Ranolazine is not for treating acute anginal episodes. It's a maintenance preventative medication.
Are there contraindications for ranolazine?
Yes. It shouldn't be used in patients who already have QT prolongation or who are taking other drugs known to prolong the QT interval, like certain antiarrhythmics, quinidine, sotalol. Also, it's metabolized by a specific liver enzyme system, CYP453A. So potent inhibitors of that system, like certain antibiotics, clarithromycin or antifungals, are contraindicated because they could cause dangerously high levels of ranolazine. Significant liver or kidney disease are also contraindications.
Well, lots of options, but also lots of nuances and interactions to consider.
Definitely requires careful management.
Beyond the medications, what about lifestyle? That must be foundational, right?
Oh, absolutely paramount. Lifestyle modification is key. Risk factor reduction is huge. That means getting hypertension and diabetes under tight control, engaging in regular, appropriate exercise, eating a heart-healthy diet, low in saturated fat, high in fruits, vegetables, whole grains, and critically, smoking cessation. If you smoke, quitting is probably the single most important thing you can do.
These are the bedrock upon which everything else is built.
Exactly. But sometimes, even with optimal lifestyle and medications, the blockages are too severe and symptoms persist. That's when we consider revascularization.
Restoring blood flow directly.
Right. That's the definitive management. There are two main approaches.
Which are?
One is percutaneous transluminal coronary angioplasty, or PTCA, often just called angioplasty, usually with stenting.
Like going in with a balloon.
Exactly. A balloon is used to open the narrowed artery, and usually a small mesh tube called a stent is placed to keep it open. This is typically preferred for less complex disease, maybe 1 or 2 blocked vessels, as long as it's not the critical left main coronary artery, and usually in non-diabetics with relatively good heart function, normal or near normal ejection fraction. Think of it like a plumber snaking out 1 or 2 specific pipes.
And the other approach?
The other is coronary artery bypass graft surgery, or CABG, commonly known as bypass surgery.
This is open heart surgery.
Typically, yes. Surgeons take a blood vessel from another part of the body, like the chest wall or leg, and use it to create a detour or bypass around the blocked section of the coronary artery.
When is CABG usually preferred over PTCA?
CABG is generally better for more complex or extensive disease. For example, significant stenosis of the left main coronary artery, which supplies a huge portion of the heart. or severe blockages in three major coronary arteries, three-vessel disease. Also, often preferred for diabetics with multi-vessel disease, as outcomes tend to be better long-term. And it's usually the choice if the heart's main pumping chamber, the left ventricle, is significantly weakened, what we call a decreased left ventricular ejection fraction, say less than 40%. It's more like building entirely new bypass roads around major traffic jams.
Okay, that clarifies the difference. Now, just quickly, to help doctors and patients understand how severe someone's angina is, there's a classification system, right?
Yes, the Canadian Cardiovascular Society, or CCS, classification system is widely used. It categorizes angina severity based on what level of physical activity triggers the symptoms.
Can you give us a quick rundown?
Sure. It goes from class 1 to class 4. Class I is basically angina, only with really strenuous, rapid, or prolonged exertion. Ordinary activity like walking or climbing stairs doesn't cause it. No real limitations. Class 2 means that there's slight limitation of ordinary activity. Angina might occur walking or climbing stairs rapidly, walking uphill or after meals, or in cold, wind, or under emotional stress, or only during the first few hours after waking. Class 3 involves marked limitation of ordinary physical activity. Angina occurs just walking 1 or 2 blocks on the level or climbing one flight of stairs at a normal pace under normal conditions. And class 4 is the most severe inability to carry on any physical activity without discomfort. Anginal symptoms may even be present at rest.
So it gives a clear picture of how much the angina impacts daily life.
Exactly. It provides a standardized way to describe functional limitation.
And that wraps up our deep dive into chronic stable angina pectoris. What we've really learned today, I think, is that angina is so much more than just chest pain. It's a critical signal, but it can manifest in varied ways. Diagnosis needs that combination of sharp clinical assessment and specific tests. And the management? Well, it's a precise, multi-pronged approach, carefully tailored.
And what truly stands out when you connect all these dots is the nuance, isn't it? Understanding those subtle differences in symptoms, like the anginal equivalents.
Right, the ones easily missed.
Exactly. And knowing the specific roles of the diagnostic tools, when to use which test, and especially understanding the medications, why beta blockers impact mortality, but CCBs generally don't, the critical drug interactions like with nitrates and PDE5 inhibitors, or the unique role of ranolazine. It's about knowing not just what to do, but why at every step.
That really hits home. It's complex, but understandable when broken down. So, thinking about all this, here's something to ponder. Given the highly personalized nature of both the symptoms and the treatments we've discussed, how might gaining this deeper understanding of chronic stable angina pectoris empower you, the listener, to ask more informed questions? Questions about heart health for yourself, or maybe for those you care about. How can we move the conversation beyond just chest pain to a more nuanced, more productive discussion about what's truly going on?